So a very good early morning from Seattle, and good afternoon to all of you, or good evening for those who are gathered elsewhere. I am delighted to join you today to present some selected results and lessons learned from the Scale Up project on behalf of my PATH colleagues and our many collaborators in Central America. Scale Up was a 5-year project with the overarching goal to facilitate government adoption of HPV testing in 3 Central American countries: Guatemala, Honduras, and Nicaragua. The project was implemented in the selected departments of the countries as shown on the map here on the slide. The core activities were transitioning to HPV testing for primary screening, including establishing lab capacity and providing the option for HPV self-sampling, as well as strengthening treatment capacity to link screen-positive women with treatment in a timely manner. For this project, HPV testing was done using Kerry HPV for the reason that this was the most affordable and suitable molecular-based test available for low-resource settings in 2014 when the project was initially conceptualized. So after specimens were collected at or near primary health centers, they were transported to centralized labs for batch processing. And because Kerry HPV is a batch test, there were 90 specimens that were needed to be collected prior to processing. And so it took on average about 1 month for women to have their results available back at the health center or through a community health worker. We did do an analysis of Kerry HPV performance in the lab because there have been variable reports on its performance under real world conditions. And we did find about 10% of plates failed. And in these instances, importantly, there was always adequate specimen left to rerun the test, and so this did not cause women to not receive a screening result, but it did result in supply wastage and wasted time processing the failed plates. Over 270,000 women were screened, and this project reached many women who had never been screened previously or were underscreened. 43% of women had never been screened for cervical cancer, and for an additional 35%, their last screening was more than 3 years ago. HPV prevalence overall was 13.6%, which is consistent with estimates from other sources in the region. And in Honduras, where we had age-specific data available and did an analysis by age, we found that peak HPV prevalence occurred between 20 and 24 years of age. As I mentioned, a key feature of the project was introducing self-sampling, and overall 75% of women elected to use self-sampling. The self-sampling was offered both at the clinics, which reduced the need for provider time and space to perform a pelvic exam. As I mentioned in the introduction, Scale Up was introduced at primary healthcare clinics in the public sector. And so these are normally quite crowded and high volume clinics. So the self-sampling really it was a great resource, was very resource efficient. In addition, self-sampling was offered as a community health outreach strategy in which community health workers brought the self-sampling kits to markets, neighborhoods, and some job sites. As you can see from the poster here on the top right of this slide from Nicaragua, the self-sampling approach was specifically advertised to women, and women repeatedly reported that they were very happy to have this alternative option to a pelvic exam. There were some differences in triage approach across the project countries, and we don't have time to get into all of those details today. But big picture, the algorithms here on the screen show the overall approach, with HPV positive, triage positive women indicated for treatment, and HPV positive, triage negative women indicated for repeat HPV testing in 1 year. And so both groups present the need for follow-up, and I'll be touching upon that follow-up for the two groups in the coming slides. While the overall treatment completion was nearly 75%, you can see in the table here and in the last row that there was considerable variation across the three countries shown here. And it's really great to be looking at the results of the Scale-Up project here so quickly after the results of some of the implementation research that was presented previously. And I think you see kind of the big difference here of when you're doing a more specific research study where you're very carefully tracking individual participants versus when implementing something at a much larger scale in clinics that are serving thousands of women and not set up, not resourced, I should say, to do as detailed follow-up. So this is one of the challenges we have as we start to scale some of these innovations up for high coverage and high treatment completion. We did have an opportunity to do an individual level statistical analysis of patient records from just 1 year in Nicaragua, which illustrates how the triage step and the triage approach can be a barrier to women receiving treatment. And so in Nicaragua, the majority of HPV positive women were triaged using PAP, but 1/4 of women were triaged using VIA, which allowed for the comparison that you see here on the screen. And what we found in this analysis was that the likelihood of women receiving treatment was 95% less for women who were triaged using PAP, which suggests that the delay in waiting for the cytology results, as well as perhaps the time and opportunity cost burden on women to return to the clinic for yet another visit, really created a pretty substantial bottleneck to receiving treatment. At the onset of the Scale-Up project, cryotherapy was the standard treatment approach for women who were eligible for ablative treatment. However, as has been well documented and I'm sure discussed here at the conference previously, there are a lot of logistical challenges with resupplying the gas in low resource settings. And so not having a consistent availability of gas and cryotherapy can really undermine the timely treatment that we're striving for. In Honduras, we implemented a prospective clinical study of thermal ablation among 319 women who were indicated for treatment of cervical precancerous lesions. We looked at a few different things, including immediate acceptability and pain experience from the procedure, and then also some clinical follow-up at 1 year. So immediately following the thermal ablation procedure, women rated their pain, and they also shared their opinions on acceptability. The average pain rating was 2.5 on the Wong-Baker visual pain scale, which goes from 0 to 10. And women said that they had no concerns recommending thermal ablation to a hypothetical friend who was in a situation of needing similar treatment. All women with SIN2 plus and a subsample of women who had a lower grade less than SIN2 plus were followed up at 1 year, and about 83% had no evidence of SIN2 plus or persistent HPV infection. It was great to see Dr. Kumar's slide on the mobile app or the mHealth intervention that they did to make sure that women got their results in a timely fashion. I think we're going to be looking to those mHealth tools more and more because especially in settings where screening may only happen 1 or 2 times in a woman's lifetime, or when triage is used to guide treatment decisions, it's especially critical to be following women who are HPV positive but triage negative. And so we observed or documented that in a subsample of women who were screened under scale-up, these initially HPV positive, triage negative women, about 36% of them tested positive for HPV, again at 1 year. And we also observed that very few women were coming back for this rescreening at 1 year on their own because it was initially a passive system with just a passive recommendation to return in 1 year. So we did not have the ability to launch a more sophisticated mHealth app reminder-based system, but in one particular area of Honduras, we were able to implement and evaluate a very simple but effective strategy of recall strategies among a subsample of women who had been screened and were indicated for this 1 year follow-up. And so we were successful at contacting nearly all of the 558 HPV positive, VIA negative women who were due for rescreening at 1 year, most of which who were reached by phone, which surprised us that phone numbers were still valid, close to a year later. 75% of these women returned to the clinic for HPV testing. On average, a woman required 2 contacts prior to return, and they came back quite promptly, on average within 10 days. So again, this was pretty low tech, but just shows how important it is to be building in systems to be continuing to monitor these women. In conclusion, the Scale Up project really advanced evidence-based strategies for secondary prevention of cervical cancer. And I want to call attention that this achievement was really a regional approach across countries in an area with substantial cervical cancer burden. However, I also want to acknowledge that despite the ambitious name of Scale Up, national HPV testing has not yet been achieved at scale with high coverage in each of these countries. Rather, this project has really demonstrated proof of concept that these substantial changes to cervical cancer screening are achievable within the public health sector in low and middle income countries, which is something we need to continue to build on. So we are hopeful that countries can learn from these successes as well as our challenges as we bravely embark on the WHO strategy for cervical cancer elimination. Specifically, we've shown that government adoption of innovative approaches such as HPV testing, self-sampling, and thermal ablation is feasible, but importantly, we need to be able to follow through with treatment completion, which remains a challenge. The cost and the logistics for procurement remain of the HPV test remain a barrier for country governments and a threat to sustainability. Lower cost, high precision HPV tests that are less technical than Kerry HPV are needed. And again, regardless of the screening tests and management algorithms that are implemented, we need to be infusing recall and retention strategies to ensure that women are not lost to follow-up during the screening and treatment cascade. My slides today and the associated publications are, they represent the collective work of many, many people. I want to acknowledge my past colleagues, especially the chair of today's session, Dr. Sylvia de San Jose, who was the director of Scale Up, as well as our many partners in Central America and the many individual women who contributed the data and experiences captured here today so we can continue to learn and build on Scale Up. Thank you very much.